Thank you very much for being here. My name is Shawn Loder. I'm a resident with the University of Pittsburgh. And today I'm going to discuss the natural history of pressure ulcers in the hospital and who benefits from surgical intervention. We have nothing to disclose. Pressure ulcers are an incredibly common problem, such that I feel confident that everyone in this audience has been affected by them. Many of us have studied them, more of us have treated them, and almost all of us have known a patient, friend, or family member who's been affected. They are an expensive problem, costing us healthcare dollars, provider hours, and patient lives. And as patients live longer and critical care becomes better, this problem only continues to grow. We are taught that a clean and durable reconstruction offers patients the best chance of recovery. However, we also know that these ulcers recur, these reconstructions fail, and that each failure predicts the next. Healthcare dollars are not an infinite resource, and moving forward, we need to be diligent in how we spend them. To do so, we need to understand what works and what doesn't. And as surgeons, we need to know for which patient an operation does and does not help. And so we set out to do just that. This study was a retrospective analysis of our own patient population. We looked at those presenting for ulcer debridement and reconstruction. And for each patient in surgical intervention, we examined demographic, medical, and surgical history, as well as the vitals, labs, cultures, and wound data collected throughout their operative and hospital course. When we track mortality along the time axis from date of surgery, we find that a quarter of all debridements we do occur within a year of death, a third within 2 years, 6% within the first month. In these tables, we display those statistically significant factors predicting mortality in our population. Blue rows suggesting greater risk, gold representing a survival benefit. Of the 208 surgeries, 18 were performed within 1 month of death. Respiratory, renal, and hepatic disease were predictive of early death, and a history of RHIS or plegia was associated with survival. 61 surgeries performed within a year of death. Again, this tracked to those patients with significant end-organ comorbidities. We next looked at the difference between those patients who progressed to reconstruction versus those who received debridements only. Survival at 1 year was significantly greater in the reconstructed population, and even among those that died, there was more than a year of survival difference between sentinel debridement. This tracked the perioperative statistics and patient selection, as patients receiving reconstruction generally had better nutrition status, lower likelihood of active infection, and greater renal function at time of debridement. Again, we find that the factor most predictive of getting a reconstruction was mechanical cause for morbidity, while malnutrition, tracheostomy, and medical comorbidity generally predicted a decreased likelihood of receiving reconstruction. And within the subpopulation receiving reconstruction, cardiac and renal comorbidities, as well as dementia and metastatic malignancy, were associated with early death. In those not receiving reconstruction, severe pulmonary disease and tracheostomy became associated with early death. Given the above data, we examined the subpopulation of those whose pressure ulcers were secondary to neurologic or biomechanical causes of immobility, such as paresis or plegia, versus those without. Within these defined subpopulations, patients with a mechanical cause for immobility tended to be more likely to survive operative intervention. They also tended to be younger and generally had a lower burden of medical comorbidities. Within our more medically debilitated population, end-stage liver disease was significantly associated with death in the first postoperative month, whereas tracheostomy was associated with postoperative death both in the first year. Taken together, these data suggest a definable cluster of traits highly predictive early postoperative mortality. Fortunately, our selection for who receives reconstruction seems to accurately track to many of the comorbidities suggestive of poor surgical outcomes. However, we must also consider the ultimate goal in these patient populations, particularly for those in whom predicted death is within the first postoperative month. Thank you very much for your time and attention, and I look forward to answering any questions.